Hi, everyone. I'm so happy to be here with you discussing sexually transmitted infections. I really enjoy talking through STIs, and they should be really easy for you all to go ahead and pick up. So we're going to go ahead and just get through the lecture. Alrighty, so for learning objectives, as usual, you'll be able to describe the microbiological etiology and clinical presentation of common STIs. We're going to cover syphilis, gonorrhea, chlamydia, pelvic inflammatory disease, genital herpes, human papillomavirus, and then trichomonas. Given a patient case, you all should be able to recommend appropriate therapy for the management of the STIs, and then you all should be able to finally provide recommendations for STI prevention for those patients that want to seek assistance. So here I have information regarding where you all can find the guidelines. The guidelines will also be posted, and they are posted into that files folder. So please feel free to go ahead and look at that. So there was a recent update to those guidelines via the CDC, and of which are provided in the files. But that update was in the management of gonorrhea. There was an update there. So that'll be interesting for us to talk through. So ultimately, STIs is it's a large epidemic for them. We know that to be true, right? That's something that we hear about in the news, that STIs and then STIs that are resistant or harder to treat is something that is definitely on the uprise. So a lot of times they are asymptomatic, and then because they are asymptomatic, they're unreported, and then that can lead to a further spread of disease. The most common diseases that are transmitted are chlamydia and then gonorrhea, and you can see some statistics there since 2014. So some predisposing factors, we see it more in men than we see it in women. In men, it can be asymptomatic longer and incubate for a longer period of time. A lot of times, a lot of STIs can versus women. So that's the reason why men often tend to transmit the STIs and to have them longer undetected complications. We see that in women, because of different things that can happen with women, meaning women can be pregnant and things of that sort. We can see a lot of complications there with STIs, especially when we consider those patients that are pregnant. Age, so those that are in teens and 20s, that is predisposing because a lot of times during this time period, patients are very sexually active, but we can't rule out our older patients for STIs. I think a lot of times when I was practicing in the clinic, we would see patients that were older and we'd say, oh no, it's no way this patient has an STI. When I saw a lot of sexually transmitted infections in those patients that were 60 and older, and that's because they don't think themselves about STIs or the transmission there, but that can occur. So you don't want to rule them out, but we know that teens and those that are in their 20s are more likely at risk. So number of sexual partners, we know that an increase in sexual partners can translate to an increase in the opportunity to transmit or to receive a transmitted disease. HIV infected individuals, and then if you have unprotected sex, that can also be a predisposing factor. So we're going to go ahead and we're going to talk about syphilis first. So the pathogen that causes it is Treponema pallidum. So it is a spirochete. It has a very thin peptidoglycan layer. So it's not your typical pathogen that you would see. So it is a spirochete. I'm going to charge you all for looking that up. If you look it up and you really determine or see that difference between the spirochete and then the bacteria, you'll remember it versus me just feeding the information to you. So how do we diagnose this? Well, we use different types of tests. So first you can use a dark field microscopy, which can pick up the actual spirochete, or we can use our non-treponemal tests. So our non-treponemal tests are not necessarily those that are specific to syphilis. It's specific to different antibodies that are created should syphilis be present in a person. So we're not very specific, but we measure them, meaning that we try to quantitatively figure out based upon the number of antibodies that are semi-specific. Does this person have syphilis? So those are our non-treponemal tests. Our treponemal tests are the ones that are utilized to actually see if we can find that spirochete that is specific to syphilis. So treponemal tests are used as confirmation. That's because they are expensive to conduct. So you want to make sure that there's an actual reasoning there behind trying to deduce that. So our non-treponemal tests, so they measure antibody directed against cardiolipin or lecithin cholesterol antigen. So it's not specific to palladium. However, when a spirochete is present, it does release antibodies that are these antibodies that are seen here. So we can kind of deduce based upon those antibody titers. So it is quantitative. So if you see an increase in titers or an increase in the amount of cardiolipin and that cardiolipin antigen that's produced, then we can say, well, if that titer is greater than 32, then or 1 to 32, then potentially this patient has syphilis. So once we view that titer and it's above that number, then we go on and we do a treponemal test, which is qualitative. So that's actually telling us if that specific antibody specific to the syphilis is present there. So when a patient has primary syphilis, you can see a canker there. A canker can be present on the vagina or on the penis, should it be a man or a woman, respectively. For secondary syphilis, you can see a rash or mucocutaneous lesions. For latent syphilis that lies dormant, then oftentimes it can be asymptomatic. But because that syphilis is there, it's just lying dormant. The minute that a patient becomes immunocompromised, then that syphilis can go ahead and wreak havoc. That's why in patients that are HIV positive, you may see them test positive for syphilis at some point throughout the time that they have the HIV. And that's because that syphilis was likely lying dormant. And then they went ahead and when they became immunocompromised, that syphilis was able to go ahead and thrive. So for tertiary syphilis, it depends on where that syphilis is. So, and then neurosyphilis can look like just a decline in the potential for the patient to be able to see well. They can have a headache and things of that sort with the neurosyphilis. And then in pregnancy, syphilis can result in fetal death. It can result in prematurity, and then it can also result in congenital syphilis, or syphilis that the baby may have. So for syphilis, it is treatable, so it is curable at most stages, and we will use penicillin. If you all remember anything, know that you will use Pen-G for syphilis. So we have different formulations of that penicillin that we will use. So the treatment algorithms will go as such. In the event that they have neurosyphilis, we will desensitize that patient. However, come hell and high water, this patient should be receiving penicillin. It is so important. This is probably the most important thing that you all need to remember from STIs is that with neurosyphilis, these patients will still receive penicillin. That's very, very important. I know sometimes you'll hear, oh, can we try the doxycycline? Can we try the tetracycline for neurosyphilis? No, we know that penicillin is able to cure syphilis. Neurosyphilis can result in a permanent loss in vision. So you want to make sure you are giving them the best therapy. So for benzathine, you will give, we see for the 1, 2 early latent, you give it ×1, or you can see every week ×3. So benzathine lasts a bit longer than our normal formulation of Pen-G. So that's why you can give it one time, because the degradation isn't as quick as we would expect of what we see here with this aqueous crystalline penicillin. So that has to be given via IV for about 10 to 14 days. But with this dosing, you want to divide the dosing, meaning you're not giving them 18 to 24. Remember, we talked about just the dosing parameters for beta lactams and optimizing that PK/PD. What you're going to do is give 3 to 4 milliunits, but then you will give that every 4 hours. So they'll be receiving it like 6 times per day. And then if the patient has congenital syphilis, then we will still do this aqueous penicillin. You all will not be responsible for knowing the dosing and such for congenital syphilis. For these other, for the other syphilis, so the stages 1, 2, early latent, and then neurosyphilis, I would behoove you to remember those dosings. Congenital, you all are not in pediatrics. You will not be expected to remember this, but it's important that you know that they still receive penicillin. So in the event that they are penicillin allergic and it is not neurosyphilis, then you can consider doing doxycycline or tetracycline. However, you will have to treat for a longer duration than what you typically would should you have given the penicillin. So the only time where you are going to give them penicillin, where you are going to desensitize them so they can still receive the penicillin, is in neurosyphilis. That's the only time where it's mandated. In the other presentations of syphilis, you can give doxycycline or tetracycline. So occasionally you can have the Herxheimer reaction. So it's an important adverse effect of penicillins observed when treating that spirochete, and it's just because of just the release of different mediators due to that treatment of the spirochete, the release of the mediators from the spirochete itself. So it can occur within the 2 to 4 hours of initiating therapy, and it's pretty much self-limiting. However, the patient may experience flu-like symptoms and may tell you that. So it's the release of the pyrogens from that infected spirochete. So we know that pyrogens are released when that's a part of immunology. So when the patient is forging that immune response or being treated with that antibiotic, then the spirochete can release that pyrogen. So management, you can use aspirin, you can use prednisone, and you can see that a lot more so in secondary syphilis versus the primary syphilis. Nevertheless, it's still pretty low on your differential of, or very low on whether you are fearful with treating the patients that have syphilis. Very much self-limiting, doesn't last long. So for gonorrhea, that's caused by Gonorrhea and is a gram-negative diplococcus. We know that Neisseria species are gram-negative, correct? We remember this from meningitis. So you want to make sure that we want to make sure that we gram stain, or if we gram stain anyway with the diagnoses, then we expect to see the gram-negative diplococci. And then we can also do the culture-based tests. So susceptibility can be performed on these tests, but more than likely you'll just go ahead and use the empiric treatment for the gonorrhea once you realize that that's what's there. More often than not, though, we will use the amplified test, so the nucleic acid test. And what that does is it tells us that the DNA that may have been isolated from the patient when we do the blood test is synonymous with gonorrhea. So that's how we'll go ahead and treat that patient should the gonorrhea be present. You won't often do a gram stain. Nevertheless, if you do a gram stain, you expect to see the gram-negative diplococci. So for clinical presentation, gonorrhea can be either symptomatic or asymptomatic. It can be complicated or uncomplicated. That's really just depending on just that onset and then that site of infection, whether it's complicated or uncomplicated. The patient can experience dysuria, urinary frequency, vaginal pain, discharge, bleeding, mild pharyngitis, or anorectal pains or pruritus, mucopurulin discharge, potential bleeding. So in males, this is typically here is listed where they typically have the infection and how long it takes for the symptom onset, and then in females where they typically have the site of infection. I would make sure you remember to keep looking at that endocervical canal, because that'll be something that continues to come up. So in terms of treatment, so in the event that it is uncomplicated, then we will use ceftriaxone 500 milligrams. So previously it was 250. So that's what when I was talking about just the new guidelines that have come out and what it is that they address, and they address a difference in gonorrhea treatment. So now we're going to use ceftriaxone 500 milligrams IM times 1, and that is if the patient is less than 150 kilograms. If the patient is greater than 150 kilograms, then we're going to use 1 gram IM times 1, just so that we can ensure that we're able to reach adequate concentrations within that patient that is heavier and potentially that volume of distribution. And then we also know that ceftriaxone can be protein bound, so we want to make sure that we are able to reach adequate concentrations. So in the event that chlamydia has not been ruled out, then we will use doxycycline. So previously we were using azithromycin. However, they've seen with gonorrhea, gonorrhea is a very resistant pathogen. So that's the reason why we use dual coverage of agents that can cover for gonorrhea. So doxycycline and ceftriaxone can both cover for that pathogen. And in the event of resistance, they have seen that doxycycline worked a bit better than the previous azithromycin that we did use. And then for chlamydia, we know that this pathogen is atypical. So doxycycline can be utilized for atypical pathogens, as we remember with pneumonia. So in the event that we have not ruled out the presence of Chlamydia trachomatis, then we want to make sure that we use the ceftriaxone and the doxycycline. In the event that you do have a patient, they're telling you the patient is infected with gonorrhea and chlamydia has been ruled out, you do not have to use the doxycycline. You can just go ahead and use the ceftriaxone. So it's important to know that gonorrhea and chlamydia, because they're the most common STIs, and they can often be there. They can often be present within patients that are co-infected. So it can also look like co-infection. That's why empirically, a lot of times we will treat for both the chlamydia and the gonorrhea. And we also consider the addition of the doxycycline for the dual coverage in the event of resistance. Nevertheless, I'm just repeating this so I can make sure it's clear. Nevertheless, if the chlamydia has been ruled out, then the guidelines recommend that you just use the ceftriaxone. All righty. And then in pregnancy, you will not use doxycycline. And I will ask this question in class because I want to make sure that you all remember why we won't use doxycycline in children, but also because it can affect bone development. And we know that that is an issue in growing children. So we will use azithromycin there. And then in disseminated infection, we will use an increased dose of ceftriaxone. And disseminated infection means septic arthritis and things of that sort. And we will treat them for about 7 days. So I don't expect for you all to know the alternatives for therapy in the event that you have a patient that you need to treat alternatively. Then I expect that you all will be able to consult the guidelines. I ask that you all focus primarily on recommended treatment. So follow-up for gonorrhea, no test of cure is needed if the patients are treated with first-line therapy. Please remember that. So if the patients are treated with the first-line therapy, which is the ceftriaxone at the various doses at certain kilograms, and then the doxycycline if chlamydia has not been ruled out, then you don't have to do a test of cure. However, you want to do repeat testing at 3 months. For these patients, irrespective of whether they receive first line or not, you want to make sure you do repeat testing at 3 months. And then you want to educate sex partners from the previous 60 days. So if you have a patient that tests positive for gonorrhea, you want to tell them to contact their previous partners that they've had within the last 60 days or so. So in layman's, and just to break this down, if you have a patient, you did not treat them with the alternative therapy, you do not have to do a test of cure, meaning that they don't have to come back in 7 days to follow up. Secondly, you do want to test them at 3 months because you just want to make sure that the infection has resolved. And then you want to have them call their previous sex partners. So when do you need to test a culture test? If the patient fails treatment, meaning that they continue to have persistent symptoms after you treated them with the ceftriaxone, or the doxycycline if that was needed, then you want to have them come back, and then you want to consider susceptibility testings or consider the fact that they may have had a super resistant infection. And then after using any alternative regimen, so in the event that that you utilize an alternative regimen and then their test of cure is positive, then you want to go ahead and get susceptibility testing for the alternative regimen. So test of cure recommendations. Who are we going to test of cure? Any patients with persistent symptoms or a patient that received IM ceftriaxone, anything other than the ceftriaxone. So when are we going to do the test of cure? We're going to do it 1 week, so 7 days after the treatment. What are we going to do? A culture is preferred from the infected anatomical site. If you cannot do a culture, then you will do that nucleic acid amplification test, and then management. If the positive test of the culture results, if the positive test comes back, then we want to send out those test results for susceptibility testing. So patients should receive the ceftriaxone 500 milligrams times the times 1 plus the doxycycline and be sent for immediate consultation with the specialist in the event that the test of cure comes back positive. So for chlamydia, this is a intracellular bacteria. So the major outer membrane is similar to gram-negative bacilli. However, it lacks that cell wall. So that's why it is that we call it a atypical pathogen. So with chlamydia, it is often asymptomatic. When symptomatic, it may not be more than just mild urethritis, so it's less severe than gonorrhea. So you may not even know that you in fact have a chlamydia infection. However, it can be transmitted alongside gonorrhea, which is the big reason why we typically treat for this alongside the treatment gonorrhea just for co-infection. So it's not always noticeable enough to send someone to the to a provider's office, but it's symptomatic, generally mild pain, inflammation, and things of that sort. Onset can be about 1 to 4 weeks after exposure, so it does spend a bit of time incubating there. So the CDC recommends annual screening. So individuals that are 20 to 25 years old and are sexually active with multiple partners. If I have a patient when I was in the clinic and they would tell me that they had multiple partners, or if they said that they were highly sexually active, then I would tell them, you know what, you need to get tested every 3 months. You know, you have your patients, you want to make sure that you can adjust how often it is that they're treated. However, the CDC recommends at the very least annually. So you can get a tissue culture. However, we typically go ahead and do the nucleic acid amplification test just to see if that DNA is synonymous with that of chlamydia. You can do gonorrhea at the same time. And then the non-amplification tests are antibody tests or enzyme immunoassays to see if chlamydia is present. So the treatment, we're going to use the doxycycline. And we are going to use the doxycycline because of the fact that, as I mentioned previously, doxycycline has just been loosely, so it's very controversial as to whether it's a better agent in comparison to the azithromycin. It's not really any strong data here. However, it's been loosely shown to be a bit better for use when compared to the doxy. So, when compared to the azithromycin. So now doxycycline 100 milligrams PO BID times 7 days is our recommended therapy for chlamydia. We remember this because we saw it in gonorrhea, in which we were treating for co-infection had it not been ruled out. In the event that the patient is pregnant, then we can go ahead and use the azithromycin, and then we have the alternative therapies there on the right, just in case. So now we have our pelvic inflammatory disease. This is our inflammatory disorder of the upper female genital tract. So acute pelvic inflammatory disease is subtle, and then it has mild symptoms. It's very easy to miss. The symptoms are non-specific, so abnormal bleeding, vaginal discharge. It can look like other STIs. However, it can be associated with definite complications, so tubal ovarian cysts, ectopic pregnancies, and fertility. So it's definitely something we want to look at and evaluate in our patients. So empirically, we want to have broad spectrum coverage. So with PID, is usually caused by just a prolonged infection of one of these. So we talked about how for chlamydia, for gonorrhea, it can be very hard for people to know that they are infected with these pathogens. They may be infected for a prolonged period of time, and they are asymptomatic. So then that can go ahead and cause some inflammation in that pelvic area. So you want to make sure that you're covering for those specific pathogens. And also when we think about just the pelvic area, we think about anaerobes, we think about gram negatives, right? Of course, streptococci can be there. So indications for hospitalization, if the patient is pregnant, if they have severe illness, meaning they have a fever, nausea, and vomiting, if they have a tubal ovarian abscess, HIV, non-response, or just intolerance of oral therapy. But many patients can go ahead and be managed outpatient. So for treatment, we will give them either the cefotetan or the cefoxitin plus the doxycycline. We'll treat them for 14 days. And then after 24 hours of clinical improvement, then we can just go ahead and give them that doxycycline monotherapy. And then we have regimen B, to where you can do the clindamycin plus the gentamicin. And then you can de-escalate to the clindamycin or the doxycycline. You all will just be responsible for regimen A, as that's the primary regimen that we see in pelvic inflammatory disease, especially per the CDC guidelines and STI management. So for outpatient management, so previously that was inpatient. So this is for outpatient, which is very easy to think about. We'll go ahead and we'll use the ceftriaxone. We'll times 1 dose. We'll add on that doxycycline, and then you can decide whether or not to go ahead and add on that metronidazole. So if you are using the cefoxitin, then you can forego utilizing the metronidazole. If you're using ceftriaxone, then I would suggest you utilize the metronidazole. We know cefoxitin has that activity against gram-negative anaerobes, and we know ceftriaxone does not. So we want to make sure we use metronidazole in the event that we're treating for PID outpatient, and we're using ceftriaxone for that management. You can use probenecid, and probenecid is there to just prolong the bioavailability of cefoxitin utilization. So that's why the probenecid is there with the cefoxitin. So cefoxitin plus probenecid and then the doxycycline, if you consider that use. But if you use the ceftriaxone and then if you use the cefotaxime, then you use the doxycycline, and then you want to add the metronidazole on board. So we also have herpes, which I will loosely talk about, not in humongous detail, but enough so that you guys are familiar. So you can have the oropharyngeal herpes, or that's caused by HSV1, and then you can have genital herpes caused by HSV2. So transmission can be from infected secretions onto mucosal surfaces or abraded skin. So the 5 stages of infection. So primary mucocutaneous infection, you can have infection of the ganglia, then you have the establishment of latency, which can be lifelong or in the sensory or autonomic nerves. And then you can have a reactivation of that infection, and then ultimately the recurrent infection. So complications can include encephalitis. We talked about how at times you can have viral encephalitis. It can be caused by HSV. It's likely, oftentimes we see HSV1 as being that cause there. It can cause pharyngitis. It can cause perithiasis, and then finally autonomic dysfunction can be caused by herpes. So for diagnostic testing, viral cultures are going to be our gold standard, and then PCR to go ahead and see if we actually have that DNA that is synonymous with HSV1 or HSV2. So for PCR is recommended in the event that we're trying to diagnose the HSV meningitis. For antigen detection, you can use a DFA or EIA, which are assays to detect that specific antigen specific to HSV1 or HSV2. So for treatment, in the event that a patient is having an active outbreak, then palliative supportive care, and then we also have the pharmacological approach that we initiate. So it's a difference in the pharmacological approach in the event that the patient has an initial versus recurrent, episodic, or if we're trying to suppress their herpes. So antivirals that we will use include acyclovir, famciclovir, and then valacyclovir. So interesting things about these drugs. So valacyclovir and famciclovir are prodrugs of acyclovir. So ultimately, they are acyclovir, which inhibit the integration of the viral DNA. So the initial episode, we can give acyclovir-based regimens for 7 to 10 days. So in the event that they have a recurrent episode, then we want to initiate therapy within 24 hours of that lesion onset. Usually there's no change in symptoms patients with prolonged or severe episodes. And then for suppressive therapy, that'll be something that we initiate in the event that there's been greater than 6 reoccurrences. And we hope to reduce the viral shedding with suppressive therapy, decrease the opportunity for transmission. And then we want to make sure that we mitigate resistance. So for the first episode of the herpes, we see that we treat for a longer duration. So when compared to the recurrent episode, so we'll be treating for about 7 to 10 days. We see that even with the therapies, they are often do you see a difference in dosing when compared to the recurrent episodic? So we're going to be intensely treating for that first episode with the recurrent episodic. Once again, you see just that difference in the dosing that we utilize there, and that difference in the days. That's something that I will focus on when you guys are thinking about treatments for herpes. So you had a patient that comes into the community pharmacy, or if you're working in an ambulatory care setting and you have to navigate this treatment of the genital herpes, really think about the days of therapy and how that differs when we're treating for the first episode and when we're treating for the recurrent episode. That'll also help when you guys are navigating through the exam and you're trying to navigate through the different dosing regimens. I will focus on the duration of days. So you're going to treat longer when you do that first episode. And then for our recurrent suppressive therapy, we'll continue this long term for these patients that we're trying to suppress in the event that they've had greater than 6 episodes. And then you can use the regimens as listed here. So for trichomoniasis, we have the etiology. So it's caused by Trichomonas vaginalis, which is a protozoan, and it can survive for several hours on moist surfaces. So we have to be careful in the communal bathing areas and in the toilets. And there are about 3 to 5 million cases per year. So it is rare that we see that in non-sexual contact, and we can see it oftentimes in females versus males. So in males, it can be asymptomatic, but if males do see something, it'll likely be in the way of clear discharge there. And then dysuria can also be something that's present. For females, it can be asymptomatic. Nevertheless, when women notice a difference in maybe the scent that they emit, then that is something that we oftentimes look for. And then upon evaluation, the women have what OBGYNs call the strawberry cervix. So their cervix looks red, very red in nature. And then they can have dysuria or just the inflammation of the vulva, the vagina, or the cervix. So the drug of choice here in the case of that protozoan is going to be metronidazole. So typically we'll give the metronidazole 2 grams by mouth times 1, and it is comparable to the utilization to the 500 milligrams BID for a duration of 7 days. So given that 2 grams PO times 1 allows for us to decrease the total dose, decreases the opportunity for pseudomembranous colitis, and then also it decreases that opportunity for the adverse events. So alternative therapies for trichomonas. So if in the event that the patient relapses, then you can consider an alternative therapy, or you can consider utilizing a higher dose of the metronidazole. So maybe like 2 to 4 grams every day for 3 to 14 days in the event that they don't perform well on that one-time dose, or you could do a 7-day dose. You can also use an additional tinidazole, excuse me, these words are tongue twisted, 2 grams by mouth times 1, so similar to that metronidazole dosing. Cross resistance is high, and it has similar adverse effects and events to the metronidazole. So while cross resistance with this drug is high, oftentimes, because I've had to manage several different cases of trichomonas, and the metronidazole is typically okay. I'll likely just defer to the 7-day course of therapy if there's a big issue. But if there is a potential of or failure and things of that sort, it's not always we can utilize this alternative therapy, but if it does fail, then it may not always be due to resistance. Metronidazole is just really kind of like our drug of choice here. And The secondary drug doesn't really compare in terms of efficacy. You're not going to get better efficacy there. So sometimes that it may not be the case if the patient doesn't perform well, that it was due to their cross resistance. So then we can also use vaginal suppositories, so clotrimazole. You can also use metronidazole there, or gentle douching. Oftentimes, I try to stay away from recommending the douching just because it can cause a lot of collateral effects in those patients that already do have that presentation of the trichomonas. So HPV, it is our most common STI, and a lot of times people just have no idea that they have it, but then it can go ahead and it can cause different cancers. It can cause pelvic inflammatory disease. It can result in infertility in women. So it's so important that we go ahead and, one, is vaccine preventable, but that we do get tested to see if to ensure that we are not infected with HPV. So HPV-6 and HPV-11 are our most common genotypes. And then HPV-16, 18, and 45 have our highest risk of cancer. And then HPV can infect stratified squamous epithelium cells and increase cellular proliferation. And affected cells may display a broad spectrum of changes. This can range from benign hyperplasia to dysplasia, and then, like I said, invasive carcinoma. So the treatment of HPV is really no consensus, but ultimately you want to remove those lesions in the event that that's something that's present. Recurrence is common, and that's just due to the latency, meaning it's due to the fact that people just don't know that they have HPV because they don't know it is because HPV doesn't outwardly present with just very severe symptoms when compared to the other STIs. So if untreated, it can be self-limiting, it can remain unchanged, or it can increase. The infection can just continue to increase the lesions if you leave the lesions untreated. And the lesions can increase in size, and then they can increase in number, and then you never know how many lesions are required, right, to go ahead and actually cause the presence of cancer. So we have to be very careful with HPV. So for therapy, you can use cryotherapy. It can be that cryotherapy can be just applied to those lesions. It can also undergo surgical or laser removal. And then there are various options as listed here for patients to utilize to remove the lesions themselves. More than anything, though, HPV, like I said, is something that is vaccine preventable. So we do want to make sure that we are advocating for these vaccines. So HPV, Gardasil originally included HPV types 6, 11, 16, and 8. And we know 16 and 8 is responsible for 70% of cervical cancers. And then 6 and 11 are responsible for 90% of the genital warts. And then Gardasil 9-valent means that it contains 9-valent and then 18-valent, meaning that it contains more strains of the potential HPVs that can wreak havoc there. And then Cervix, it was discontinued, but there may be patients that say that they have had it, and it protects against HPV 16 and 18, which can cause just that presentation of, or it can cause the cancer. So those are HPVs that we see in cervical cancer. So the vaccines are protective in the event that the patient has not been infected. So if the patient has been infected with HPV, then them getting vaccinated against it likely won't resolve anything. We want to make sure that we kind of come out swinging in the event that we know that HPV is present and that it can cause cancers. So we want to make sure that we are advocating for routine vaccination starting at age 11 or 12, and then it can continue into the mid-20s if the patients have not been previously vaccinated. So we also have EPT, or expedited partner therapy, and that's the delivery of medications or prescriptions by persons infected with an STI or STD to their sexual partner without the clinical assessment of the partner. So actually in California, their pharmacists can go ahead and prescribe the expedited partner therapies for syphilis, gonorrhea, chlamydia, and NDC. Pharmacists can do it for trichomoniasis as well. So you can go ahead and get a prescription for your partner, and the partner can be serviced against the STI. Because it's the idea that if you have it, then your partner either gave it to you or you have given it to that partner. So we want to make sure that we talk about sex to our patients, and infectious diseases is a really big place for pharmacists to really go ahead and show how integral and important we are to public health. So we want to tell patients that sexual urges are powerful, and we know that sometimes accidents do happen. There are times where protection isn't utilized, and that can translate to STIs. We want to make sure that we try to promote the action of safe sex as best as we can. So we don't want to stigmatize the patients that get STIs. It's not just dirty people, or that idea of people that are dirty or careless get STIs. It happens every day. We want to be willing to reply honestly and clearly to patients' sexual concerns. So we want to be honest with them. We want to be clear. We want to be transparent about their sexual concerns, and we want to be empathetic. That's who we need to be as pharmacists. We're arguably the most accessible healthcare provider, and we want to show why that is the case. So we want to be as neutral and as human as possible without being too personal. Keep teaching brief, straight to the point. Want to make sure it's direct, and be familiar with the condom and lubrication products that are available at our site. When I was in my residency, we often had condoms available at the HIV testing area, and I was able to tell them which condoms it is that we did have, and things of that sort. You will find people that are allergic to latex. They want to know if you have lambskin and things of that sort. So you want to be able to let them know that. So options, there are condoms for men and women. There are a variety of colors, sizes, shapes, flavors. We can have flavored condoms, lubricants. They should not be used, however, for vaginal or anal intercourse if it can be avoided. At times, these flavored condoms or the lubricants can result in potential infection. So we want to be sure that we are telling the patients that, and they can cause a lot of sensitivities when used in that private space. So you can utilize the condoms with the spermicides as well. It's important that you do tell the individuals that they have to use the spermicide with the condoms. The spermicides cannot be used alone. They're most effective when utilized with the condom. However, some studies have loosely suggested that the spermicide can increase the transmission of HIV, and is likely, of course, with these studies, is likely due to the fact that patients are not using proper protection when utilizing the spermicide. So that's a really big place for education. Tell the patients they have to use the condom with the spermicide. And then types of condoms. Natural latex condoms are really good for disease prevention. You do not use these condoms with oil-based lubricants. Flavor varieties are the best for, let's say, oral intercourse, not necessarily just the private part to private part intercourse. You want to be very careful, as previously mentioned, with that. Synthetic condoms are more expensive, but they are good for disease prevention. So polyurethane is less elastic than latex, so it may break and can be used with oil-based lubricant, no latex odor. Polysporine, softer and then more elastic than the polyurethane. Lambskin is much more expensive, and it is made from the sheep intestine. A lot of patients will state that they have more sensation with the lambskin when their partners use lambskin condoms, or the patient, if it's a male themselves, may say that. Nevertheless, it's important to let them know that these do not protect against disease. Lambskin condoms do not protect against STIs. While they may protect against pregnancy, they will not protect them against an STI. So you want to let them know that it's because the actual membrane of those condoms are not, they are too large, and they allow for different things to go ahead, and different bacterias and different bacteria and viruses that are causative of these infections to seep through. So you want to make sure to let the patients know that and tell them that they would be better served utilizing a latex condom and one that is not flavored if they wish to have genital to genital intercourse. If they want to use flavored condoms, then that's best for oral intercourse. So I will see you all when it's time to talk about STIs. Please feel free to go ahead and put questions into the message board to continue to discuss the topic. Have a great day.